So good morning, friends and colleagues. Good evening. Thank you very much, Julie, for organizing this very, very important workshop. My name is Prof Wonkam. I'm a medical geneticist. I'm a professor of medical genetics at University of Cape Town and deputy dean for research. And I will be talking today as the principal investigator and director of SickleARC Data Coordinating Center. That is one of the sister consortium within Sickle in Africa, the other one being Sparkle, that is led by my friend Julie Makani. I think we are all converted to the story of sickle cell disease. I would like to stress that this is the first monogenic disease of humans in terms of numbers. Is also a disease that see a high burden on the African continent, with nearly 80% of newborn that are born in Africa, and it become prevalent, as everyone knows, because of resistance to malaria for those that are heterozygous. Sickle cell disease become known to modern medicine more than 100 years ago. And the panel on the left-hand side described the first laboratory findings that describe the sickle mutation. But since more than 100 years, there is only one efficient medication that is available for treatment hydroxyurea. We are aware that there are evolving medication in the pipeline following a few clinical trials. This means that, and even the hydroxyurea have not been initially dedicated to sickle cell disease. A comprehensive care that includes newborn screening, follow-up patient, antiviral prophylaxis, and other therapy have allowed the drop of mortality in most high-income countries in children to nearly zero. It is not yet the case in Africa, but the mortality in adults, even in the US, haven't changed for the past 50 years. Adults will all die for cardiovascular complication in their fourth or fifth decade. It means that there is a challenge for care, prevention, and treatment of sickle cell in all parts of the world. In Africa, the epicenter, but also in diaspora in Europe and in America. The only way we can allow ourselves to fight this is to establish a longitudinal cohort that will allow proper study that will help us understand the pathophysiology, environmental factor, genetic factor, and also a proper treatment of the condition. While the increase and the high burden of sickle cell disease in Africa will allow the coordination of such study, unfortunately, most African countries have not had resources until recently to establish such multi-country cohort to address some of the issue of sickle cell disease that is needed globally. Fortunately, Sickle in Africa was established a couple of years ago. I think the very first meeting that sets a Sickle Pan-African network started in Tanzania in 2014. And following that, the NHLB has launched two calls. One to establish a data coordinating center for sickle cell disease. On the screen, you can see the member of the SADaCC that have allowed the establishment of the coordinating center for the past 3 years, and we work hand in hand with Sparkle. SADaCC is based at the University of Cape Town, and for past 3 years we have established a solid base for coordination of research on sickle cell disease based on 4 major pillars. The first is management, the second is establishment of resources and tools, the third is LC. We have established a database, and we have also developed some training and initiate some research activity in collaboration with Sparkle. The first meeting of Sickle in Africa happened formally in Tanzania in November 2017. And since then, we have had at least 5 meetings across the continent. And the member of Sickle in Africa at the moment include Tanzania, Nigeria, Ghana, that are SPARCO member, and the coordinating center in Africa. But in light orange are countries that are part of the Pan-African Research Network that also form part of the network that have allowed us within SADaCC to set the first sickle ontology, which is the first control vocabulary on sickle cell disease that have been reported so far. This is probably one of the proudest outcomes of establishing a sickle data coordinating center. And this ontology at the moment that is available online, freely available online, that are now been translated in French and in Portuguese, include more than 1,500 words on sickle cell disease. Some words are new, some were known, and we also have included some specific innovation, for example, by suggesting calling sickle cell disease banana cell disease. That will fit very well with the ecology where sickle cell is very prevalent. The sickle cell ontology have allowed us to frame the development on a database for sickle cell disease that will serve as a strong platform to coordinate data from various SPARCO sites and also additional sites that will hopefully be added to Sickle in Africa very soon. This is the schema of activity of SADaCC, of course, including the 3 SPARCO sites and additional sites. And we have planned not only to extend our activity to coordination, database development, research, training, and to initiate a data analysis or data plan for a biorepository. We have also developed some innovative way of collecting data, for example, using RedCap and cell phone.
One more minute, Ambrose.
Implemented in study site. I will respect my minute, Julie. And this have been only possible with collaboration with our patient in a very ethical way. And our database have a strong quality assurance that we have also developed. Our public engagement have been very efficient. Actually, in about 2 hours, I will be giving a similar talk for Sickle Cell South Africa. And our engagement with patients have been also efficient globally, as Gravidis, this patient here, which is the leader of Sickle Cell South Africa, have been part of a Nature paper exactly on gene editing. It is our hope that this seminar today will be a starting point to think more carefully on gene editing in Africa. Thank you very much.
I also like to